Thank you, Chairpersons. Thank you, Dr. Chavla, for giving me opportunity to be present over here. My topic is the management of type 2 diabetes in compensated and decompensated liver disease. I'm starting with the topic which Dr. Chavla has already covered. Why we are taking this? Because there is a high prevalence of type 2 diabetes mellitus in patients with chronic liver disease. It impacts the prognosis and increases the risk of complications, overall mortality. The decompensated cirrhosis is associated with renal dysfunction, hypoglycemia risk, malnutrition, and sarcopenia. There is an effect on drug metabolism and excretion of the drugs and needs a special focus as standard of diabetes guideline does not address the cirrhotic patients and management requires individualized and cautious approach. This has already been covered that the type 2 diabetes mellitus increases the risk of NFLD. The insulin resistance is an independent predictor of fibrosis in hepatitis C infections, hyperuricemia and hyperglycemia. They are associated with hepatitis C infections and C and B and diabetes mellitus and C infections. They have a bidirectional relationship that in diabetic patients, the incidence of hepatitis C infection is more, and in C infected patients, the risk of diabetes is also more. As sir has already discussed that the patient of cirrhosis have more chances to have diabetes, IGT, but close to 100%, that is nearly all patients are insulin resistant. And fibrosis is the thing which is increased with the prevalence of diabetes mellitus. And insulin resistance, if we see this chart that the sir has already told that in liver cirrhosis, there is a decreased hepatic clearance of insulin leading to hyperinsulinemia. And this hyperinsulinemia increases the risk of increase the incidence of counterregulatory hormones and the insulin resistance in the liver and the muscles, which in the liver it might lead to diabetes, and the other factors also responsible for decreasing the function of beta cells. So all the setting is of hyperinsulinemia, and this is the thing which sir has already told as hepatogenous diabetes, that there is an incidence of hyperinsulinemia in cirrhotic patients. There is insulin resistance and ultimately beta cell dysfunction, which can lead to diabetes, even if the patient is non-diabetic and is only having chronic liver disease. This has already been discussed, but one important thing that in Indians, in Asian population, we have lean NFLD also. The person are lean, but still they are having NFLD, and this has already been discussed that there is a bidirectional relationship between type 2 diabetes mellitus and NFLD. NFLD can lead to insulin resistance, which can ultimately lead to type 2 diabetes, and type 2 diabetes can lead to ultimately NFLD. So there is a vicious cycle which one is before, which one is after is not there. And impact of diabetes on various stages of liver disease, we can say in normal liver it predisposes for NFLD. In chronic liver disease, there is a faster progression of fibrosis. In end stage liver disease, there is a decrease in overall survival and the risk of complications, and liver transplantation, again there is an increased risk of diabetes mellitus. So it is linked to increased incidence of hepatic encephalopathy, variceal hemorrhages. It is an independent predictor for bacterial infections. It has increased risk of hepatocellular carcinoma, and it significantly decreases the survival rate if the patient of CLD is having diabetes mellitus. There are numerous studies which depict that there is an increase in complication of CLD in patients in the presence of diabetes, and there is increased mortality in the patients of CLD if the patient is having diabetes. So if we go for diagnosing and monitoring of the decompensated CLD, the important thing is that we must remember that the fasting plasma glucose is a gold standard for diagnosing diabetes, but the threshold for fasting plasma glucose decreases in chronic liver disease, and it is not being justified, but it has been said that the cutoff of 126 is lowered in cirrhotic patients, and it should be around 110 to take the patient as diabetic. Postprandial glucose again is a factor by which we can diagnose, and OGTT is the gold standard. HbA1c has a debatable role in patient of chronic liver disease because of the decreased erythrocyte survival. The alternative biomarkers can be glycated albumin, fructosamine, and the important thing is that we can go ahead with the self-monitoring of blood glucose and CGM. Coming to the management, which was the main topic, in the absence of specific guidelines, the treatment of diabetes mellitus in patients with CLD starts from the general principles of management. That is, if we see a patient of type 2 diabetes, then be compensated or decompensated. In decompensated liver disease, the only option is if we have to give insulin However, in compensated liver disease, all the drugs can be used with or without caution and can be avoided. We can go ahead with them one by one. The important point to remember in patients with CLD is that the fasting blood glucose may be lower in CLD and cirrhosis. Glycated albumin may be unreliable in cirrhosis, especially in patients with shortened lifespan red blood survival. Glycated albumin and fructosamine reflect glycemic status more accurately, and self-monitoring of glucose and CGM can be considered. The challenges which we face are diagnostic difficulties, which we have already discussed. There is a high risk of hypoglycemia because of reduced insulin clearance and low glycogen storage and impaired glucogenesis, as Sir has already told. There can be drug-related issues due to decreased altered hepatic metabolism and protein binding, portosystemic shunting leading to higher drug levels because of decreased first-pass metabolism, and risk of hepatotoxicity with some agents. And there are other challenges are cognitive impairment because of encephalopathy, renal dysfunction, and malnutrition and sarcopenia complicating the diet therapy. The targets for decompensated liver disease, we should go for relaxed targets, as AD has already said that there should be less stringent A1C goals for the patients who are having limited life expectancy, extensive comorbid conditions, and advanced micro and macromolecular complications. So, child-pug A is basically compensated cirrhosis, and B and C are basically decompensated cirrhosis. So, in A, we can have a target of less than 7.5, and B and C, we can have A1C target of around 8. The fasting plasma glucose should be kept between 90 to 150, and post-mortem blood glucose should be below 200. Diet is most important, in which we should achieve a weight reduction of 5 to 10%. The accepted approach is we should start off with, as there is a incidence of sarcopenia also, we accepted approach is about 35 kilocalorie per kg body weight per day should be given, and then we subtract 5, 10 or 15% in case of mild, moderate or severe ascites. And this should be the average requirement of the body weight. Protein intake should be 1.2 or 1.5 gram per kg body weight, and deficit of vitamin should be supplemented. Physical activity is very important because it is also recommended for NAFLD, and the aerobic and resistance training exercises can be done. So, to summarize the lifestyle intervention, caloric needs is 35 to 40 kilocalories per day, protein intake 1.2 gram per kg per day, and sarcopenic patients or malnourished patient 1.5 gram per kg per day. Meal planning, it should be small, frequent meal, high protein, late night complex carbohydrate snack, and avoid prolonged fasting. Physical activity should be done, and we should avoid excess calorie restriction because it worsens sarcopenia, and processed food and fructose-rich beverages should be avoided. Coming to pharmacotherapy, it is guided by child-pug score. We can take one by one. Metformin, it has benefits of improving insulin resistance. It promotes weight loss, and it is usually weight neutral. It decreases the risk of HCC and encephalopathy if given in the patient of compensated cirrhosis, and improves survival. The only factor is that of MALA, that is metformin associated lactic acidosis, and it should be not given when the eGFR is less than 30. So, coming to the where it should be used in child-pug A and B, it can be used with the lower dose, that is less than 1 gram per day, and child-pug C, it should not be used. Sulfonylurea and meglitide, they should not be used in any of the drug, either decompensated or compensated cirrhosis, because they had a increased persistence of having hypoglycemia, and they are potentially hepatotoxics. Coming to thiazolidines, they improved steatohepatitis, so it is better if the patient is having NASH. The concern in cirrhosis is that there is an increased risk of fluid retention, edema, ascites. It can worsen osteoporosis and can possibly increase cardiovascular risk, and there is limited data in advanced cirrhosis. So in child-pug A, it can be used with caution, but B and C and decompensated CLD, it should be avoided. DPP-4 inhibitors, the safety is in all the cirrhotic patients because they are weight neutral and they have lower hypoglycemia risk. However, in renal impairment, the dose should be adjusted. The linagliptin has the safest renal profile, so it can be given. In A, it can be given. B, it can be used with caution, and C, it should be avoided. The important thing with DPP-4 is that some of the studies have shown that it increases the risk of going into complication, that is encephalopathy, and progressing to fibrosis is more with DPP-4 inhibitors, but it is not well documented. Coming to GLP-1 agonists, they have a benefit of weight loss and improved NASH, and lower hypoglycemia risk, so they can be used. It is not metabolized in liver, but exenatide and lexazinide should not be used in renal failure. Again, A and B, that is compensated cirrhosis, we can use it, but in decompensated cirrhosis, it should be avoided. Similar in SGLT2 inhibitors, they improve glycemia and weight, improve NFLT and acidosis. The case report that it decreases edema and ascites can take into consideration diuretic-like action. However, concerns are hypotension, urinary infection, and less effective when the GFR is less than 45. So, in A and B, they can be used. A, they can be used. B, with caution. But C, it should be avoided. Alpha glucosidase inhibitor, again, they improve the patient having hepatic encephalopathy because of they decrease proteolytic flora and amino production. They increase saccharolytic flora and have mild laxative effects. So they improve hepatic encephalopathy. So they benefit in cirrhosis. However, they have minimal systemic absorption. So they are safe in cirrhosis also. So they can be given in childbook A and B, but in C it should be avoided. Insulin therapy, it is preferred for decompensated cirrhosis. It is reliable when all drugs are contraindicated. The challenges are that there is a hypoglycemia risk, there is a weight gain and association of increase with hepatocellular carcinoma in some studies. How to start? It should be started with the 25 reduction dose with the dose of 0.1 to 0.2 unit per kg per day, and the prandial insulin can be added with the largest possible meal. It can be either 4 units or 10 units, 10% of the basal dose, and titrated every 3 to 4 days. And monitoring should be SMBG or CGM. So this is the main protocol. The patient with diabetes, we should start off with lifestyle intervention, then pharmacotherapy. If the patient is stable, not acute event, or in A category, then if we are having hypoglycemia risk, then we should consider the drugs which are having low hypoglycemia risk, such as SGLT2 inhibitors, GLP-1 receptor agonists, DPP-4 inhibitors, and alpha glucosidase inhibitor. However, sulfonylurea should be avoided. If the concern is obesity, then weight neutral drugs or weight losing drugs should be used, such as SGLT2 inhibitors, GLP-1 receptor agonists, and DPP-4 inhibitors, but sulfonylurea and pioglitazone should be avoided. In renal dysfunction, renal safe drugs should be used, such as linagliptin, SGLT2 inhibitors, but the exenatide, lexazinide, and metformin should be avoided if the eGFR is less than 30. If the patient has encephalopathy, then the patient and the drugs which improve encephalopathy, such as alpha glucosidase inhibitors, they should be used, and the targets should be kept lower, considering which have low hypoglycemia risk. If there is poor control, then we ultimately switch to insulin. However, if the patient is having decompensated cirrhosis, then the insulin should be started, as already we have discussed. This is the titration regime which I have already told about, that we start off with 0.1 to 0.2 units per kg body weight, and we increase gradually. The fasting plasma glucose is 90 to 150. In NFLD, as sir has already discussed, coming to a special consideration in patients with hepatic encephalopathy, having cognitive impairment, we should avoid secretagogues and long-acting insulin, and frequent glucose checks are needed. In renal dysfunction, metformin should be avoided. In DPP-4 inhibitors, linagliptin is the safest, and exenatide and lexazinide, they should be avoided. In sarcopenia and malnutrition, the protein requirement should be around 1.2 to 1.5 kg per day, gram per kg per day. Avoid strict calorie restriction and prefer agents that do not worsen muscle loss, such as GLP-1 receptor agonists and DPP-4 inhibitors. If the patient is having hypoglycemia risk, then high in decompensated cirrhosis due to decreased glycogen glycolysis, so use metformin in the low dose, DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 AGI wherever possible, but sulfonylurea should be avoided. In transplant, we can skip this. You can see in this chart, child book A, B, and C, all the insulin can be allowed in all the cases. If we go for sulfonylurea, it is not recommended in any of the thing. Meglitide is again non-sulfonylurea like secretagogue, it should be avoided. Metformin, child book A and B, glitazones A and B, DPP-4 inhibitors A and B, GLP-1 A and B. However, exenatide and liraglutide should be avoided, and alpha glucosidase inhibitor A and B, and SGLT2 inhibitor A and B. So in child book classification, A and B we can use, but in C, that is decompensated cirrhosis, it should be avoided. So this we have already discussed. So we can start off with lifestyle interventions. we can assess the child pox class, start off with safe OADs, then if patient is in B or C, then we start with insulin and monitor with SMBG and CGM, and in special situation we should act accordingly. So the take-home message is insulin is the safest and preferred therapy in decompensated cirrhosis. While oral agents may be cautiously used in compensated state, management should be individualized, balancing safety and glycemic control. Thank you.